Hello, fellow classmates. You have stumbled across Maggie's and I's video over our research proposal, and we hope you enjoy our presentation. Maggie and I have been extremely interested in self-injurious behaviors and the interventions that are put into place. We have experienced ones that have not been ethical, and we wanted to come up with an intervention that would be ethical and safe for the client when they are engaging in self-injurious behaviors.
All right, hello. For this research project, the research question that we came up with is when a client is engaging in self-injurious behaviors, is ignoring and forcing the client to finish the triggering task while they continue engaging in SIB truly effective in decreasing the behavior of SIBs and teaching alternative behaviors such as communication? And what are ethical replacements to both effectively decrease the frequency of self-injurious behavior as well as increase functional communication skills?
When completing our lit review, I found different articles that talked about different interventions and studies that have been put in place to look at the decrease of behaviors. The first article we will look at is self-injurious behaviors in children and adults with autism spectrum disorder. They tried to conduct their study different in order to come up with the same findings that other experiments were finding. However, they could not come up with conclusive results. We use this article to look at the interventions that were put into place, and also looking at the functions of SIBs that they were outlining in their article. We found it interesting that they were very upright about the differences in their study versus others, and how we might want to look at that, because when you are looking at self-injurious behaviors, there will always be an FA done, and there needs to be environmental factors taken into place as well when looking at self-injurious behaviors. The next article we looked at is Self-Injurious Behavior in Functional Analysis, Ethics, and Evidence. They completed a study looking at what interventions can be used with SIBs, and they were specifically focusing on functional communication treatment and how it could serve as a replacement method. We used the study that was conducted in this article when coming up with our own intervention as well, since this study was showing that functional communication is an extremely effective replacement behavior for self-injurious behaviors, including antecedents and consequences, and just teaching it throughout. We realized that we can use the information found in the study to help us form a better intervention plan for self-injurious behaviors, as the main goal is to decrease them and have a replacement behavior that is not only socially significant but safe and functional for the client. Now, the next article we looked at is Understanding the Experiences of Self-Injurious Behavior in Autism Spectrum Disorder and Implications for Monitoring Technology Design. They implemented different interventions between the correlation of managing SIBs and technology use. The technology use meaning that they were showing them visuals and different presentations throughout their day to see if it would help decrease self-injurious behaviors, as it also gave them a different way to communicate. We used this article because of the different interventions that they stated throughout the study. The interventions that they put into place are very specific, and it helped us to look at what we could put into place for ours as well, and what pieces seem to be really effective in decreasing self-injurious behaviors. The next article we looked at is a systematic review on non-medication intervention for behavior of individuals with autism spectrum disorder. We found this article extremely important because it was looking at non-medication interventions, which in a clinic setting, or honestly in any setting outside of a hospital or other things where they may be obligated or allowed to use medication, we will be using non-medicated interventions. So we use this study by also looking at the different interventions that they found were successful in decreasing SIPs. They completed interventions using functional communication, blocking, redirecting, following through, and etc. It allowed us to look at the successful interventions and ethical interventions that we could put into place for ours as well. The next article we will look at is treating self-injurious behaviors in autism spectrum disorder. This article does state things that we may not agree with. However, the biggest thing that this article states also supports the idea that functionally communicating can decrease the probability of self-injurious behaviors as it is an effective replacement behavior. Because this article looked at different studies and was able to conduct one of their own, we decided that we wanted to use this article because it says support our intervention that putting functional communication in as a consequence strategy can aid in decreasing self-injurious behaviors.
This is an introduction to the participants we will be using. The first is under a pseudonym Henry Smith. Henry Smith is a child diagnosed with ASD. Shelby is the one that works with Henry as a technician, and after receiving parental consent, Henry will qualify and be one of our participants. A little more information about Henry is he engages in self-injurious behaviors, the hypothesized function being escape, as the behaviors occur after demand or aversive event is put into place. He attends services at an ABA clinic for 8 hours, 5 days a week, and he just turned 3. Our second participant is under the pseudonym Willow Jackson. Willow Jackson is a child diagnosed with ASD, UDD, and PTSD. I'm the one that works with Willow as a behavior health specialist in a pediatric inpatient facility, and after receiving parental consent, Willow will qualify and be one of our participants. Some more information about her as well. Willow engages in self-harm and self-injurious behaviors in the form of scratching and or biting herself. She responds positively to female staff due to a history of SA from men. She typically needs verbal prompts in order to communicate when she wants to self-harm and will accept a fidget toy as an alternative behavior. She enjoys reading outside, doing puzzles and origami, sleeping and talking to others. Willow does not respond well to staff intervening physically when she is self-harming because it makes her need to self-harm worse and instead prefers verbal prompts.
The DV that we will be looking at is the measurement of the frequency of self-injurious behaviors. We are looking at 2 different participants, so there are 2 different operational definitions for each of them. For Henry, this operational definition of self-injurious behaviors will be any time this client engages in behaviors actively trying to harm themselves. This will look like head hitting their face with an open arm, hitting their body with an open arm or open hand, or stomping forcively on objects. These behaviors will only be tracked when they are in negative affect, meaning after demand has been placed or an aversive event has taken place. For the operational definition for Willow, this will be any instance or attempt in which the client scratches or bites physical contact between tooth and skin at their own skin with either their own hand, fingers, or nails, or a physical object.
Okay, and here is our intervention, the intervention that we came up with that ties in with the purpose of our research. At the onset of SIBs, the practitioner will not provide attention to the behavior itself by withholding eye contact and verbal commentary. Of course, a pillow or crash pad will be available for especially dangerous SIBs, and the practitioner should intervene physically if necessary. They will wait 10 seconds to let the client calm down before saying something along the lines of, "Let's take a break," or "Let's find a different activity," and setting a 3-minute timer to allow a smooth, calming transition for the client. The client and practitioner will then engage in a preferred and rewarding activity of the client's choice for 10 to 15 minutes. After the activity, a 5-minute break will be provided, during which the practitioner will provide verbal reminders that they will return to the previous task, such as X more minutes, then we'll do previous task, as well as offering alternative strategies. which could be offering to help, breaking up the task in intervals, or splitting it up over time. And this will make the task less triggering and decrease the probability of future SIBs. Now we're going to break down the intervention for you. So for the onset of the SIB, withholding attention during an SIB decreases the amount of triggers and overwhelm in the client's environment, which causes them to stop engaging in the SIB sooner rather than later. SIBs are typically a physical manifestation of something such as internal frustration or an inability to functionally communicate, which is why withholding attention momentarily is set in place to allow the client time to calm down rather than aggravating their behavior by getting physically involved. In the Let's Take a Break section, we provide verbal prompts which are crucial to the intervention because it allows the client an opportunity to communicate their needs. Communicating in these particularly overwhelming situations can be very difficult, so we provide the client time to calm down and then aid them in functional communication. Following the 3-minute break, the practitioner and the client will be engaging in a rewarding activity, which also essentially acts as a continuation of the break, but it also provides confidence in their abilities, which is super important for when they have to engage in the previous task later on. This activity also provides automatic reinforcement, but it's important to ensure that they are still providing verbal and physical reinforcement as well, such as high fives or saying things like "great job." After the rewarding activity, we provide verbal prompts during a 5-minute break, letting them know that we will return to the previous triggering task, and this is necessary to aid in regulating emotional reactions and making a smooth transition. This basically models to the client that they can use breaks in the future as coping mechanisms, both preceding and following overwhelming or difficult tasks. Prior to returning to the triggering task, it's important that you facilitate a plan with the client because it will make the transition into and the upcoming task itself easier. This also models problem solving in stressful situations for the client. This element of the intervention not only teaches the client they have control and individuality in their own environment, but it most importantly demonstrates that engaging in the self-injurious behavior does not aid in avoiding the task. And to wrap things up, as you can see, our intervention's purpose is set up to prioritize the client. Their comfort and their safety is emphasized. Through modeling and open communication, the client learns how to utilize functional communication and coping mechanisms to tackle frustrating or overwhelming situations. Those behaviors are being reinforced, and returning to the task in a modified way exhibits that we do have control over our environment, and engaging in self-injurious behavior does not aid in avoiding the uncomfortable situations. Thank you so much.